Hey everybody, John Kublank here, and we have another exciting episode of Off the Cuff, all things healthcare. And I am joined with the most amazing person in the entire world, the best nurse of all nurses. The information that comes from this person is like gold. Miss Arlene Maxim, how are you?
I'm good, John. It's been so long since we've done this.
I know.
I'm excited about getting new information out to people. Thank you.
Yeah, and it's not like there hasn't been a lot of new stuff with the moratoria that has come out for home care, home health, and hospice. That was, I think you were telling me for months that this was probably going to happen, but I think it shook up a lot of people, especially individuals that just got started or were just looking at getting started. That changed a lot for them. But how is this affecting the entire industry, and what do you think that it's done for home health and hospice right now?
Well, it's really interesting because the moratoria on hospice and home health is something that happened. So those folks, like you said, who were trying to enter into the program or are new at it, just won't be able to do that until this is lifted. And by the way, I don't think, and everybody thinks I've got this crystal ball, like you mentioned. I told you a few months ago this is probably going to happen, but I think that this is going to last a year and a half, or maybe even 2 years. So I think that we've just got the tip of the iceberg being shown to us, and it's going to affect us for a time to come.
Yeah.
So as far as the effect on home health and hospice, like I said, the moratoria is one thing, and it happened, and that's the title of this whole rule. However, I did an article, and it's called The Downdraft, and it's the effect that the moratoria rule is going to have on all of us, every single one of us. And I think one thing we want to leave today with, and we'll talk more about this, and if I were any agency in the United States, I would have this written on my wall somewhere and on the door when people walk in. The compliance is king. This is a time when we cannot play around. And for the past number of years, in particular hospice, I think that we've underestimated that the education for hospice, and not provided the education that was necessary for hospice for them to understand. So much of the documentation has gotten, truthfully, it's just gotten sloppy. And so what we have going on now is a tightening of that for the agencies that are in business and who are probably legitimate agencies. Now, every time you turn the TV on today, tomorrow, probably for months to come, you'll hear about fraud, particularly in hospice, but also in home health. And the fraud exists with the fraud that they're advertising exists with those operations that just were, I don't know what they were trying to do, but just billing for services that they just never did. That was a large group of it. We heard about the 800 organizations, both hospice and home care in LA, but there is a lot of other fraud that goes on, and it could be organizations that have been in business for a very long time. So I think that, like I said, it covered the tip of the iceberg, uncovered the tip of the iceberg, and we're going to be seeing a lot more. So with that being said, what we have to do on our end is to train our staff, make sure that we're in compliance, make sure you know the conditions of participation, make sure you know the medical policy manual in either hospice or home health. And if you don't have those documents, and I tell you, I've gone into agencies where they've been in business for 10 years, and I walk in with the conditions of participation to do an audit, and they asked me where I got that. They'd never seen it before. So there are organizations out there that don't have Appendix B or Appendix C for hospice. And so if you don't have it, John's going to put an email up for the the two of us, and we will get that to you. So you need that. You need that as far as making sure that you are in compliance.
I think also one of the things that a lot of well-intentioned agencies are going to run into, and my heart hurts for them, because like you said, there's probably, it's probably more negligence, is probably the best way to go about it. Or, we've been doing it like this forever, or my last administrator did it like this, so that's why I did it, right? All these excuses. But fraud under a statistical microscope, when they're bringing in all this data, I think it's going to be really hard to determine what is actually fraud, and they're going to see these trends. And like you said, the trends are going to look like fraud. So you're going to have a lot of these well-intentioned agencies getting caught up and getting shut down, maybe not even doing the worst things in the world. Again, well-intentioned, but they're not going to care about it. They're really looking like they're trying to slash a lot of agencies across the country. I believe there's somewhere around 20,000 agencies total, give or take, 1,000, I think there's 12,000 home health agencies, 6,000 hospice agencies, something like that. What do you think the goal would be or do you think there is a goal for limiting that number down, or is it really just going after the fraud?
I do. And one of the things in the proposed rule they talk about is it's almost like they're going to put a CON on every state, and they're not calling it that, but they said they're going, with the enrollment issue, they're going to be looking at that as far as geographics and how many organizations are within that geographic area that someone's applying for. Going back to the point that you made about the way folks are taught, that's a really, really good point. And I think it's something that folks need to really, really pay attention to, because just because you were taught a way does not mean it's right. So unless you've had, there's a very large consulting firm that just went out of business, and just in the last couple of weeks, unless you've had really, really good consultants or people that have been in the industry and have been through some things, you may not be in compliance and not even know it. You may think you are and not even understand that you aren't. I'm working with an agency right now that they are a legitimate organization, but they just haven't been taught correctly. So I just think it's really important for people to sit back and think about who taught me. Many times, I've thought about writing a book called, I can't even remember what I was going to call it, but anyway, it had to do with, it was called Guessing, Gossip, and Greed. And the guessers are the folks that are in the business for a while, and then they get out and decide they're going to start their own operation because they've learned everything they needed to learn in 6 months. Oftentimes, those are nurses who think they get into hospice and they do the work for a few months and they think they know. So those are the guessers. The gossipers are typically people that sit around a table. They all have an agency of some sort, whether it be hospice or home care, and they talk about, how did your survey go? What deficiencies did you have? Can I borrow your policy? And so many times I'll go into an organization and the policies are just a mishmash of lots of different copies, sometimes total copies of somebody else's policy manual. They've never read their policy manual. And one of the things people don't understand is your policies trump the rule. So even though the conditions of let's say, for instance, the conditions of participation say you have to supervise your aide every 14 days, 2 weeks. If you say you're going to supervise your aide every week, that becomes your compliance issue. And so if you're not doing that, then you will be found with either a standard level deficiency or a condition level deficiency, depending on what the surveyor is looking at. So I think, folks really need to be paying attention to, where did I get my training? How current is it? And you need to keep up. I'm telling you, things are changing every single week. And by the way, I just wanted to mention that I write something called the Maxim Memo and it's the hottest news every single week. We get inundated with so much, and now it's on the news, so we can't even turn off on the TV without listening to it. But we get inundated with so much information, so many newsletters and that type of thing. I boil it down and get to the hottest topic for the week that you need to know about, and write a document on it. And it's free. If you go on, if you just look up Maxim Memo on the internet, you'll be able to find that. And I did write a 2-part series on the moratoria and talked about the downdraft effects that I mentioned earlier. So it's a good free piece of information, and you will get what you need to operate currently, but you need to know what the basics are for staying in compliance.
And you were helping me through the survey that I had a client that was helping, and I think it's another just nuance is if you're using a consultant, do they understand the state regulations in which there are, because there's the federal regulations, right? But then there's the state regulations. And you said something interesting too, that the policy and procedure trumps, but it only trumps when it's more than the condition. So you can't underwrite the condition of participation either, which I've seen. I've seen agencies try to underwrite the condition of participation and be like, well, we don't do it like this. It's like, well, you can't do that, and we've talked about the fraud. I think part of the issue where we've gotten with the fraud, and maybe it's by design, maybe it's not, is that we're pretty, the industry is pretty trusting, right? Like that we're doing what we're supposed to be doing. And, for years I've heard, and you kind of said it, we're inundated with too much information, not enough training. But with technology the way that it is now, with access resources, depending on your EMR or depending on what you do, there's really no excuse not to know. It's just putting in the time or getting good, resources like Maxim's Memo. So it boils down so you're not having to hunt it all over the place, but not doing anything is really not an option anymore. And I don't think an excuse.
Yeah, it's interesting. Access started something called Access I, which is a trademark for Access. And with that, the nurse can actually go in and search for things related to her client base. It's a very interesting concept, and it saves so much time and so much effort. If you haven't seen that yet, I would go into the Access program or call somebody from Access and talk to them about it, because it's very, very interesting. And it's certainly not taking over the job. It's something that's probably already been completed and you're just searching for something. But you're right, AI is going to be, we're not going to talk about AI today, but AI is certainly going to have a place in this whole thing that we're going through right now. This isn't the first time. And I think that's the other thing that folks have to be aware of. This is not the first time we've had the scrutiny that we're having now. It's gone on before. Some of you older folks will remember IPS, the interim payment system that happened back in the 90s. And we lost a good percentage, more than 40% of our home care companies. And, they said even at that time, and today I hear the same comment, they're never ever going to shut down agencies. It's just not going to happen. They can't do that. Well, they did do that. And they did it for home health. And so it can be done if things get serious enough. And the IPS was a whole different thing, but we've had a number of times where we have had to rethink what we're doing. In 2000, OASIS came about. And one of the very good thing about OASIS was that gave birth to the EMR. That's the first time. We had we had Epic, and we had some things that were going on in the hospital that they tried to adapt to home health. But in 2000, there was the need. You had to have an EMR, or you were going to spend hours and hours and hours in handwriting documentation. So things have happened before. We've gotten through it before. It's going to be tough this time, because back then what they did, they changed the rule, they changed the payment system, they took money back. And they started OASIS, which was actually a good thing, because we didn't really have an assessment, a formal assessment, and there was no data that was being able to be collected to find out who was good and who was bad. So now we have that. But in saying that, I just want everybody to understand, the sky is not falling. We're not, Chicken Little isn't out there. It's a change that we're going to have to make. But right now what's happening is the compliance is going to be looked at so carefully. And I think surveyors will be getting involved in things. They did say in the final rule that there will be some changes in the conditions. Not a lot, but I think there will be some, and probably in both home care and hospice. So there are things that we're gonna have to learn new things. And learning new things sometimes is hard, it's taxing. And with the nurses that are out there that do home health and hospice, most of them are in the baby boomer age. And so they're going to be retiring soon. And we're going to be left with clinicians and a workforce that is very technology savvy. So they have to make sure that they're screening for technology that's going to be compliant for them. And I don't think the technology, well, I know the technology isn't going to take over the human touch of things, but it's something that we need to be aware of. And so we need to be training up these clinicians and teaching them. So for those of you that have been in this business for a while, like 10, 15 years, it's time to, try to do some education with the folks that you're working with and make sure that we've got an industry that's solid at the end of this. And like I said, I don't think it's going to end, it certainly isn't going to end in 6 months, but I do think it's probably going to take 1.5 years or 2 years before this ends.
And I work with multiple industries, but you said it with ours, but I think it's across all of them today. We don't do enough to invest in our employees for training and ongoing training. And it's not, I always say that I'm like one of the most unlucky people because I'll get into hospice and then, I'm hearing all the stories about, we go on these conventions and we do all this. I never got to go any of those things. Basically nobody is really investing, or less and less people are investing in, the conferences. Now we're going to do webinars, but people don't seem to be taking it very seriously. And that's where I feel like if we would just take the training seriously, take orientation from the start seriously, we would be able to essentially cut down on that compliance issue. Start at the beginning, do the things first in the beginning, so you're not having to play catch up at the end. I think a lot of times, Six Sigma, black belt, lean sort of gets a bad reputation. But ultimately, Toyota, when they came up with lean manufacturing, it was to solve the same problem. They were having too many QA issues at the very end of their assembly line, which when they looked at all their numbers, they said, oh, dang, this is actually costing us more money, putting us at more risk, because if we would just fix the screw in the beginning, we wouldn't have all these problems. But what we know as humans, but we don't follow as business owners or operators, is that if we kick the can exponentially tends to get bigger, right? So
that's true. And and you're very right about orientation and training. And there was one report that I read that indicated that clinicians leave home health and hospice within the first 6 months of employment because they don't understand it. They didn't have a proper orientation. And so orientation is so very important. And oftentimes, and I've been in agencies where somebody's come in to apply and the administrator asks for a copy of their license and gives them a list of things and asks them to check off the boxes and sign it. And that's it. That's their orientation.
That's 90% of everybody's orientation today. It's sad that it's not about training. It's about checking a box to be good with the state. That's it. We want to be in compliance, but that you're missing the whole point of what in compliance means. It means that your staff is actually orientated. They're not orientated, so you're not in compliance.
Exactly. And then the ongoing training is another point. And again, I do a lot of the training for access, and I think that they really have a very unique and very robust training certification program. I would encourage you to look into that. And I'm not here to advertise access, but I know the quality that goes into it, and I know that the clinicians behind the scenes are actually award-winning clinicians. I myself have two national, well, I have an international Stevie Award, and I have a McKnight's Award. And we're the ones that are doing all of the writing and some of the videos. You've probably seen me on webinars. I just completed a webinar last week with Access. And even though I'm a senior consultant with them, I play an active part in things that go on as far as education is concerned. So you're absolutely right. The orientation is one thing, and getting the basics, understanding the conditions of participation, understanding what's covered and not covered. And by the way, as we get into this, I just want to bring up that palliative care now has been added to the list of items that CMS is going to consider covered. Now, what CMS said in the proposed rule was that palliative care has always been covered, and it's not a new benefit. So we have to keep that in mind. It's not a new benefit. They are going, from what I understand and from reading the proposed rule, they are going to add that to the home health list. You know, there's 15 things in the list of, in the Medicare Benefit Policy Manual, Chapter 7, of things that nurses can do. And so palliative will be added to that. Now, that doesn't mean it's just nursing that can do palliative, but and I'm not sure how they're going to write it, because they're including all disciplines. One of the things that I've pointed out to folks is that there is something in the proposed rule that says that the palliative requires spiritual intervention, which is correct, and we don't have chaplains in home health. And you know, there are a couple things with palliative in that I am a little concerned about. You know, there are a lot of hospices that have already included palliative in their hospice program. So how that's all going to shake out, and if the surveyors in home health, and I don't know this, but I'm just thinking as a surveyor, if I'm a surveyor and I know that palliative is covered in home health, number one, I'm going to ask them why they're not doing it. And number two, for seriously ill people. Number two, I'm going to ask them, if they don't have a hospice already included in their program, where is this bridge? Palliative care is going to be a bridge. Where is this bridge going to take this patient? Are you contracted, or do you have some agreement with another hospice? How's that going to happen?
They better have a partner, because you don't want them discharging, you know, randomly to somewhere and hurting your value-based.
You don't have a plan. That's exactly right. And so it's so interesting, because so they're asking for RFIs, a request for information, from home care, hospice, and from physicians. Just last week, the physicians' proposed rule came. Physicians' fee schedule came out. And in that, they've asked the physicians for an RFI. I don't believe that this rule related to home care and palliative is the end of the road. I believe it is a door that's been opened, and I believe that they're going to get information, and I think they're going to get a lot of pushback on this. They're going to get information from all three entities, from hospice, from the physicians, and from home health, and believe that there's going to be a big change over the next year or two in palliative care. They've had demonstration projects going on since 2012. Every one of those demonstrations, and there was one in 2016 that they did, there was 141 hospices that were included in the demonstration project for palliative care. I don't know of any home health that's been included. So why they put palliative in home health, I don't know.
Well, and I had a question on that too for you. You said that there's not really chaplain use in home health, right? So, you could contract that. That's fine. That's not that end of the world from a hospice. But my big thing is palliative care. Definitely the mind shift is different, right? From curative to palliative, right? Just right there is different. In home health today, the medical director, if you have one, which is not required, doesn't do anything, right? And so if you have a medical director, I highly doubt that they're going to be pumped about now filling calls and orders for palliative care if they're not very comfortable with it, if it's like an ortho surgeon or something, right? And then two, expanding on that, most of your home health referral sources, right? They're managing their patient. Oh, now I want to switch them from curative to palliative. But again, this PCP or this ortho or whoever is like, I don't know anything about palliative really, or they're even if they want to continue and they say they do, they maybe are not trained well enough on that particular care path, right? And I've seen a lot of physicians, and I'm not trying to be criticized, but I think humans do it in general. When they don't know something, they back away, and it's like, I would rather have somebody else deal with it. Yeah. So I agree with you. I don't understand why they put it in home health versus hospice with the system set up the way that it is.
Well, you brought up a good point though. It's not just the physicians. One of the things that the home health organizations need to understand is they need to train their staff now on patients. Not that they haven't taken care of patients with serious illnesses, but this is I think this is a different pathway. And so the serious illness definition needs to really be addressed with the clinicians, and they need to understand that this is different. The palliative is different than the typical skilled care, the wound care, the IVs, that type of thing. These people can have ongoing treatment. They can keep seeking treatment for their disease. They don't have to have a terminal disease as a diagnosis. That's another thing. They're going to have to make sure, the home care companies are going to have to make sure that they have coding companies, if that's what they're using, or the coders that they're using, must understand how to code palliative care, because that's going to be different than coding routine home care and like curative care, like rehabilitative care. So it's going to be different. They are including all of the disciplines in there. But I certainly would, and I'll probably say this by the time we get done with this, but you need to comment on this. You need to send CMS letters. They do read the letters. I promise you they do. And so we have had, and I was trying to think of an example before we got on here, but we have had things changed because of the comment letters that have been submitted. So I would encourage you as an individual, as an agency, even your patients, to send letters out to Congress and let them know that you're not happy with this. This is not the way this should be set up. It shouldn't be thrown together like this just because they think they need to have one. It shouldn't be thrown together like this. I mean, and the thing is, these people with serious illnesses, just like a hospice patient, they should be encouraged to get out and do activities. These patients are going to have to be homebound.
Right.
Now, I heard from somebody the other day that they were going to take that requirement out, but I don't know how they can do that without taking it out of the whole home health.
In my only experience with palliative too, which I think no agency would be prepared for, especially a home health agency, is hospice patients that are critically ill. You're not hearing from the patient very much, especially as they progress in their prognosis. You hear from their families or whatever, but it's mostly by the time you kind of had to handle the communications really low. The one experience that I had when we started a palliative program, the phone calls were exponentially higher of both home health and hospice. It was like 2 to 3 times the amount of phone calls, because these individuals are at the very beginning of the hospice process. So they're the most emotionally fragile. They have the faculties typically to make phone calls or to get out of the house. They're not at the end, right? So you have a huge influx of communication and requests for visits that I also don't think that we would be prepared for, especially on the home health side when you're doing per visit. Wait. I have to pay, let's say 3 extra visits as a, 100 bucks, $150 now. And palliative, it doesn't have any reimbursement. So I don't, like, that's one thing that I don't see really working out, and why we need to be vocal about it. And like you said, right. And be a part of the solution, and not do anything. But I do think it's going to be a process. And if anybody's doing it just for money, right, I think that's going to be the biggest trip up, because it's not.
Yeah. Well, and I think technology is really going to take a place here. I mean, it's going to have to. Like remote care monitoring and that type of thing is going to be something home care companies need to be looking into, because like you said, the phone calls are going to be coming in, and many times it's not anything that you actually have to go out and do. Many times it's just reassurance, just talking to them, giving them recommendations for how whatever solution there might be with it. But it's
but that for an
but then we didn't get paid for that.
No, you don't get paid for it. And I feel like, and that you hit the thing, you don't get paid for that phone call. That's where agencies, I think, have the biggest heartburn, and it hits them so fast, is that they get so inundated with this increase in communication that it's like, oh my gosh, I had no idea. But that's what happens. That is what's going to happen.
Yeah.
You won't be able to. And I think that it goes along with the customer service, right? So if your customer service goes down, then everything starts to break down. You're not going to get more referrals. Your referral sources are going to hear back from their clients, and they're going to
affect your value-based purchasing, because you've got critically ill people or seriously ill people that aren't going to get better. They're only. I mean, our goal is to transition them over to hospice. And so your value-based purchasing scores are going to go down. So think about that. Those of you that are watching this, think about that and how you're going to handle it in your organization, whether you're even going to do it. I mean, it doesn't say you have to. Now, one of the things I wanted to bring up is that and I don't think I said this yet, but the proposed rule says that this is not a new CMS policy, which it is not. However, that does not mean that you cannot advertise a new program within your organization. So like, for instance, wound care is covered, and a lot of organizations advertise their wound care and their statistics and their satisfaction with the wound care that they provide. What's another one? IVs, if they have an IV program.
Yep.
And you have specialists, like in wound care, you might have an interstomal therapist. With palliative, that's a different program for you. It's not for CMS. CMS is saying we should have been doing this all along, and why didn't you do it, and that type of thing. But for us, it's new. And there are some home health agencies that I know do palliative, but this is going to be different. It's going to be much more structured, and it's going to be different. So don't let that wording confuse you. When folks say, oh, you can't advertise this as a new program. You can. It's a new program for you. You're specializing in this. You put together something that was going to be effective for your company. And so don't be afraid of that. How you're going to work it. I've got some ideas on how things should work with palliative, but this whole scenario, and I think I don't know, John, if you have anything else about palliative that you want to talk about. Was there?
Well, I feel like CMS, the government, even with this moratoria, is asking operators, owners, the industry to zoom out, right? And palliative, to me, right, even though on the reimbursement side and the policy side, we're not really sure how things are going to work out. My view is that we're just trying to expand that continuum, like you said, bridge the patient. We see that there's a gap there at the at the 30,000 foot view. I think the issue that most operators have is that while CMS wants us to zoom out, they're zooming in at the very detail, right? The dollars and cents of everything and how it goes. But a really well-defined palliative program, I think, is essential to the continuum of care. I think it could provide a lot of benefit for your hospice program. I think long-term it'll benefit for your home health program because, again, your value-based purchasing, you're going to have at least, the transitions correct. And I think long-term, zooming out over the next 5 years could do really well for you. But if you're in a PE sort of process that you're trying to sell in 2.5 years and you're cutting every expense so that your bottom line looks better, it's probably not going to work out for you.
The first thing they cut, with my experience, the first thing agencies want to cut is orientation and training and marketing. And those are the three things that absolutely should not be cut. And I guess that's why I wanted to transition a little bit into compliance, because this is, I can't tell you how important it's going to be, like as of today, as of several months ago, as of years ago. But now I can tell you that there's been increased audits. There are different types of audits coming up. The audits are going to be painful. I've talked to a company that has actually it's Gateway, that does medical reviews and that type of thing, and with ADRs and all medical reviews. And one of the people there told me that the ALJs now are not necessarily looking at the Social Security Act for direction as far as coverage is concerned. What is happening in many cases, and I'm not sure if it's 100%, but many cases are bringing in someone from the QIO, and they are bringing position papers with them and convincing the judge to go the way of the government rather than the agency. So even if you have someone you provide a very, very good care with, if you're not watching those LCDs and the local determination coverage and the NCDs, you're going to have a problem. And so I would encourage everyone to download those, in particular hospice. Hospice has to be documenting according to LCDs and NCDs. Home care has them too. So I would encourage everybody to download those and get those reviewed and understand that their documentation, their coding needs to comply with what the LCDs are saying.
Yeah, and we've said it all episode and we've said it before, but like negligence really isn't an option anymore. And I love this saying that the fish rots at the head. And with a lot of people that I've worked with over the past several years, all of the new information, all the changes, they create an anxiety and they put off the education. But if you, the leader of the organization, doesn't know what's going on, how could you expect the people underneath you to stay on top of it as well? So I really think if now is the time more than ever for whoever the leader of the organization is to put orientation and training at the very top of the priority list, because that's going to help on the compliance side. You can't expect your nurses or your staff to keep you in compliance if they don't understand what it means to be in compliance.
Exactly. Yeah.
And the time it takes to do the orientation and to do the meetings and that sort of stuff, I think, with the virtualization of home health and hospice now, that people are doing meetings over the phone and these sort of things, and even the webinars like y'all do are great, but it sort of passes the buck again back to the employee to say, hey, watch this video on your time and do it while they're taking care of kids or doing what they're not listening. But at the end of the day too, the owner probably didn't watch the video anyway. They just shoved it to the nurse and said, Arlene sent me this and said all my nurses need to watch it. But if you yourself don't understand, your agency's not going to get it. And I believe, at least from my personal experience, there's been a lot of people that have just been lucky, for the past years.
Oh, absolutely. Oh, yes.
And I don't think we're going to have that opportunity to be lucky anymore with technology increasing, with data increasing, with access that the government has to our information. It's going to be important now more than ever to scrutinize. But if you spend all your time in QA, and I just went through an audit where we had 10 patients audited for a year. It was over a year time period. It took like 5 individuals to pull together all that information. 4 of those individuals were the highest paid individuals in the organization, right? So I'm just seeing direct dollars flow to the organization that they've done the right thing at the beginning, right? And had all their nurses trained, had everybody doing it, we wouldn't have had that sort of problem. So you're going to pay for it one way or another. Might as well be proactive instead of reactive.
Yeah, and I think that's the way many organizations function, is they function reactively rather than proactively. And that's unfortunate because we have the tools together to do a proactive approach to this. And QAPI programs, I think folks underestimate their QAPI program and the impact the QAPI program can have with the success of your home care company. And one of the things I find in QAPI is that organizations will take a whole list of things and put on their QAPI program. And that's not going to be effective for you. 2 or 3 things that you really want to focus on should be part of your QAPI program. And there should be some results. It almost should be like a care plan for the agency, or a plan of care for the agency. So you start out with the beginning with the problems, you establish goals for that and interventions for that, and then you follow through and see if your goals are met and give yourself some time limits for that. But I think it's really important that, and what I've seen most DONs get hung up on is measuring data. It needs to be measurable, right? So no anecdotal. And I was telling a DON, I was like, the way that you take care of your patients, like you said, this is the way we should take care of our agency. But we got to zoom out, and you need to make sure that it's actually something you can track. It's not, and it's not a superficial. It needs to be data driven to meet compliance standards. Right. Yeah. And if you have an EMR that has a really good dashboard available for you, that's going to help you. And it's just a matter of getting used to that. The technology, I just see technology as being a huge part of what we're going to see as far as collecting data, being ready because CMS already has that data. Hospice just got their PEPA reports last maybe 2 months ago. And CMS has that data. Now, I heard someone say last week that CMS is not looking at the PEPA reports. I don't believe that. It's part of CMS now. It used to be part of another company, but now it's part of, if you look at the PEPA link, it has CMS's name on there. So CMS has that information. I doubt very much whether they're going to ignore billing issues and all the types of issues that come up with the PEPA report.
Especially with hope being new.
Exactly. Well, yeah, and so another thing I heard was that the PEPA report for home health is supposed to come out this month or next month. So we should have that. We haven't had for almost 5 years now. And so that's going to give us a good idea of, at least give us a place to start, and to particularly collect the data on that. Your IPR reports and your APR reports for value-based purchasing for home health is extremely important. I'm actually for Access, I'm actually writing a toolkit for value-based purchasing, and taking each one of those areas and dissecting them and say, okay, so your staff need to be educated on that, because what's happening now, there are some organizations I've talked to had no idea about value-based purchasing. They don't even know that it's going on, and they don't know that they're losing money. They don't understand that they're losing cash. And because we're going to be scrutinized so overwhelmingly, we have to accept any cash that the government will give us. And, if you look at the proposed rule, it says that they've got a 2.4 increase for home health. I don't think we've seen that word increase in home health for many, many years. Hospice, yes. However, if you read in the fine print, they will also tell you there's things that they're taking away. We still have that clawback, like multi-million-dollar clawback for home health. So there are things that they're going to take away. They're not just going to give us an additional amount of money and not balance that out and everything be budget neutral. It's just not going to happen. So I think that some folks get overexcited about the word increase.
Sure.
They don't read much further to see what's really going on as far as the money is concerned. So
and that brings me to a thought I wanted to get out too. We've been talking about technology and getting the knowledge. But I follow a lot of these Facebook forums, and I've used ChatGPT and other things. And there's people, including ChatGPT, that are just flat wrong. And so we need to be very careful about dedicating and understanding what is a true good source of information. Because when the state walks in the door, you're not going to be able to point to Ginny 35 on Facebook and say that, she said that this is the compliance standards. And it's like, nobody,
that's
cares.
Really good point. Social media does not drive policy. I'm telling you, you need to know what these policies are yourself. And there should be things keeping you up at night. When I owned a home care company, and even now, because I worry about my clients as well, there are things that I worry about as far as the industry is concerned. It's difficult, and folks are looking at losses, they're looking at audits, they're looking at more difficult surveys, and they tend to not attend, like you mentioned, conferences. Not even the webinars aren't necessarily something that you necessarily have to pay for. They don't have the time to do that.
And I find that the webinars are like, during the day. It's hard to do the webinar at 1:00 on a Wednesday, especially when your patient called 30 minutes ago and they just requested a visit and your nurse is out sick that, it's like, that is home care, operations. You never know what the day's going to hold. It's hard.
Well, those are typically recorded so you can watch them at your leisure. But I do think that there should be part of education built in every week, and maybe even an assignment from the CEO or the administrator to the clinicians on which webinars or which podcasts or which educational program that they need to complete by the end of the week. Maybe there should be an hour out in a week for just education. I mean, that's not a bad idea. So,
I won't talk long on it, but one of the things that I've been pushing all of my friends and clients on education, I'll put it in the link for this show, is Notebook LM, which is a free tool that basically gives you everything that you would need to learn on a subject. And if you are, like you said, the owner, administrator, and you're leading the education, it makes it very simple to get true sourced information that you believe is good, like not random, again, Ginny 35, it's CMS or Maxim's memo or whatever, you're putting all this, and then it creates a podcast or a video or an infographic or whatever that you could send to your staff, and then you can talk to them about it. And it's, again, free and very easy to use. So going back to what I said earlier, there's just no excuse not to be doing what you need to do today, because we have all the tools available to get it done, up into basically everything for free. So gotta get on top of that. And I think what you're speaking this week, where?
Oh, in Florida at HCAP.
Yeah. Nice.
I'll be, if anyone is listening from Florida, come up and say hi. I'll be happy to meet you. I do have a few tips that I'd like to just end up our session with. So my first one is to make sure that CMS, you've written a comment letter to CMS. We have a 60-day comment period. It ends the end of August. So make sure you get those letters in, again, from your staff. The more letters we can get in, the better. Make sure you start looking for palliative care education, if that's what you choose to do, if you choose to put together a palliative program. And in physician engagement regarding this as well, making sure that you have a physician that's helping you with that. That's going to be really important. And John made some good points that most of the time the medical directors now in home health do little or nothing. However, something I forgot to mention, in the proposed rule as well, there was some information about hospice at the end. One of the things they brought up was the medical directors being involved with so many hospices. They're going to limit that. So they're going to start watching the medical directors very, very carefully. So I
don't want to go off on too big of there, but that worries me. I'm excited about it because one of the things that we hate in the hospice industry is that the medical director, you can never know where their loyalty, quote unquote, lies, especially if they have 5 or 6. But on the clinical side, right, I have worked with palliative certified medical directors versus non-palliative certified medical directors versus no knowledge of hospice at all. And there's a huge difference of somebody who is palliative certified versus the other two. And so if we are forcing hospice agencies to go out and get physicians that are purely doing it for a paycheck, that they don't have a heart for palliative care or a clinical mindset for palliative care, that could cause long-term effects, I think, because they're not going to go, most of them are not going to go back to school to get some sort of certification.
Right.
So I do worry about that a little bit.
Yeah, but they do need to stay up to date with things. I know some physicians, they get certified in hospice or palliative care, but they don't update their skills. And so they get behind in what's current. So I think we have a responsibility to make sure that those physicians are kept up to date too.
Absolutely.
A formal compliance program, I think, is absolutely critical now. Having a compliance officer, making sure that you understand what a compliance officer does. There are a number of companies that do compliance certification, and you might want to look into having one of your staff members who can do something like, it doesn't have to be an attorney. It can be, anyone that has a good thought and gets along with people. You want to have a compliance officer that your staff are going to feel comfortable coming to talk about an issue with compliance they may see needs to be fixed or addressed.
And one of the bigger statistics that I've heard specifically about healthcare is by not having that person that people like and trust, people are just shoving problems underneath the rug.
That's right.
You're never going to find them or not fast enough.
Yeah. So having, and then making sure that, you have your compliance officer is active, that they're not sitting in an office watching videos on their screen or something, that they're actually an active part of your organization, and that you have your staff know what your compliance program is. That's another thing that happens is you have one. Sometime, and I've had an attorney say to me that one of the worst things you can do is have a compliance program and have a binder and all that kind of thing. Have the OIG come in and ask, do you have an active compliance program? And they already know where you're out of compliance. And you say, oh, yes, we do, and hand them the binder, and you're not doing 90% of it. That's worse than not having one at all. And I'm certainly not promoting not to have one, but what I'm saying is make sure that whatever compliance program you have written documentation, you've thought it out, you know what you're going to do, you know who's going to be reporting to whom, Some agencies have a red phone. They have a red hotline phone that they use for people to make complaints. But you want to make sure that your organization is transparent. The less transparent it is, the more likely you are to have audits that you don't expect. Like John said, making sure that you know your data, that you're looking at your reports that are coming through, the IPR, the APR reports that are coming through for value-based purchasing and home care, the PEPR reports that already have been exposed for hospice, and then of course PEPR will be coming out for home health. Go ahead.
And I want to jump in here too, because these reports typically and always double check, but most of these reports coming out of the government don't have PHI. It's just straight data. And a lot of times, especially if you're new to looking at the reports, it can be a little overwhelming. And again, we're not talking about AI today, but I have successfully ingested reports and got good information out by using AI that was way more accessible to my client than the PEPR report. And it was able to, it was IPR report, but either way, it was able to give actionable data very quickly. So again, do something with the report. If you're not reading it, get an LLM or ChatGPT or something to digest it and summarize it for you so that you can do what you need to do to fix it, because that's where all of your issues are going to be at, or not all of them, but you're going to see them, where the issues are.
Yeah, the light's been shown on them. Making sure that you've got the right technology. And, one of the most painful things to happen in an organization is switching technology. EMRs in particular is one place that is painful. And you want to make sure that you have technology that is going to give you what you need. Because it's cheap does not make it good, does not make it does not make the information within the technology that you have good information. Like you mentioned earlier, it's like you're penny wise and pound foolish. I think that's the term we use sometimes. Where you don't spend what you need on technology, and you end up with horrendous surveys, you end up with horrendous audits from the federal government, and they cost you so much. Just to go through an ADR process and to go all the way through all the steps, and it's getting more difficult because they are using AI in the first couple levels of determination now. And so using those LCDs that I mentioned earlier, and anything that you can get your hands on that's going to help you with being compliant as far as documentation is concerned. But the technology that you're using, Access has just extended its training and certification program to folks that don't use Access. So if you're part of another software, you might want to take a look at that, because as I said, the educators behind the scenes that are doing their home care and hospice experienced people. They're not just folks that came in to do education. They've actually had experiences. I've been doing this now for over 40 years, so I know of what I speak. I've been through it all. I've been through it from the beginning. I actually started when they first developed the Medicare program for home health. So it's interesting to me to see the different technologies, and you can kind of tell, particularly the training programs, you can kind of tell that they don't have, whoever's doing the education does not have the background. They're just they've read a book and they're reciting the book. They're reciting what they read in the book. So having that hands-on practical experience, nothing can beat that. The experience is just so much. But I guess what I want to leave with today is those are my 5 tips for being successful with this. But what I would like to leave today with is make sure that you have your compliance in order. Compliance is king. I said that in the beginning, and I just want to repeat it because that's what's going to get you through this next couple years. And we are going to get hit. I believe we're going to get hit hard. and we better know what we're talking about. And I think hospice is going to feel the heat more than anything. You know, home care has been under scrutiny for a long time. Have they learned their lessons? Sometimes not. You and I have been in organizations, and we know that some folks just don't learn lessons. No matter how many times you say to them, this is what you need to do, they just don't learn the lesson. But if you have, you know, the serious sanctions that the surveyor can offer with immediate jeopardy, I think we're going to see more sightings on immediate jeopardy in the future. It's going to get tough, and so John and I are here to help you if you need consulting or anything like that. That's not what this podcast is for, to advertise anything. It's to give you information that you need. But we're certainly here to answer any questions, and our email addresses will be posted, I'm sure. And so
yeah, I think you said it right there, and I said it, I want to say it's asking more questions, you know, having a conversation, but also, like we said, be very cautious about where the information is coming from. And I think you said it earlier too, we need to expand the information to all staff. Your front desk receptionist should understand value-based purchasing from, you know, a high level, and how they directly impact it, how everybody is impacting the organization, and how the outcomes are going to be impacted by everybody's role within that organization. It can't just be held at the top anymore. That information has to cascade down to everybody, so that everybody gets on board, you know.
That's right.
Yeah.
Yeah.
Awesome. Well, thank you so much, Miss Arlene. This was a great episode, and I wish you all the best of luck in Florida this week speaking. I know you're going to do great.
I hope to see somebody there that has listened to the podcast. So
yeah, make sure you go up and say hi.
I look forward to seeing. It's going to be fun. We're going to do a skit. So.
Oh, okay.
Yeah.
Getting your acting chops get out there, huh?
Yeah. So it's going to be a funny skit. I get to wear things in my hair and. Okay.
Awesome. Well, make sure you take pictures so I see.
I will. Okay. Thanks. Bye-bye.
Awesome. Thank y'all. And we will be back with more episodes. We're going to be trying to get them out more and more, but like and subscribe so that you can stay up to date when we put on content. And as always, thanks.